lectures. Next, we have a very interesting talk about role of anti-reflux procedures in preventing cancer. It will be given to us by Dr. Abdurrahman Al-Fadda. Dr. Abdurrahman is a interventional and therapeutic endoscopist. He's the head of the Advanced Therapeutic Program at King Faisal Specialist Hospital and Research Center in Riyadh. He's also an associate professor at Al Faisal University in Riyadh, and he will give us this amazing talk. So
thank you, Dr. Maghrabi, for this great introduction. I'd like to thank Dr. Imad and the organizing committee for having me to present a very interesting topic about the anti-reflux measure in management of esophageal cancer. So here are my disclosures. So I was thinking that before I start into the topic itself, it's great to look into the impact of esophageal cancer into the incidence and the prevalence of esophageal cancer, and what modalities that we can do and improve to reduce the incidence of esophageal cancer here. So as we all know, esophageal cancer is the 8th most common malignant tumor worldwide. Especially in the eastern part of the world, so maybe we have to keep an eye really as the incidence of this disease is more in our country. So the incidence, as I said, have been increasing due to several reasons looking into this. So first of all, the global aging and the population growth is the first common cause. And due to the increase in the prevalence of the associated risk factors that you can see below. What is unique about esophageal cancer, it's one of the cancers that are extremely malignant, and if it's diagnosed lately, the prognosis is over poor. So a major effort has been done to look into the prevention of the esophageal cancer in those patients. Now looking into the data worldwide, you can see that around 80% of esophageal cancers occurs in the area that we so around 80% in Asia, and 5 out of the 10 top countries that have been suffering from esophageal cancer is as well in Asia. So maybe, as I said, an effort has to be done to reduce this cancer as much as we can. Looking into the data, predicting it in the next 10 to 20 years, you can see in the eastern part of the world, the incidence is very high. By 2030, it's going to be increased by 25%, and by 2040, it's almost 50%. So it's really getting on the rise. And that will cause more mortality as well if these cancers were not treated in a proper and sufficient way, for which an antireflux looked at to help to reduce the incidence of Barrett's esophagus and esophageal adenocarcinoma. Looking into the literature, this is not quite new. We've been talking about now of different endoscopic modalities to treat anti-reflux and the reflux mechanism that can in the future prevent the presence of Barrett's esophagus and adenocarcinoma. Looking into the anti-reflux therapies, it can be used as an alternative to surgical therapy or a definitive treatment, especially with small hernias. And it can be as a bridge sometimes between pharmacological treatment that the patient is receiving and the surgery itself. Now, before 40 years or more, the first reflux surgery was done by Dr. Angel Chick, and it's called Angel's procedure. And I think this was a very GE junction area, and looking into it, as you can see, it's obvious here in the X-ray. This have been done a reasonable and a good result. but we can see that it's been reported to have a lot of complications, necessitating a minimally and less invasive techniques to treat reflux in patients who's complaining of gastroesophageal reflux disease. Now, when we do anti-reflux therapy, what are the best candidate or those patients who we need to do for that? I think it should be one of the main staying possibilities and options for patients with reflux disease with small hiatal hernia. Patients who are not willing to continue in a long-term use of PPI, or those who are non-responding in a good dose of PPI as well. Patients who does not want to do a surgical therapy or are not qualifying for endoscopic therapy as well. It has been proven by evidence in different literatures now that endoscopic treatment of anti-reflux been proving efficacy. It has a shortened procedure time and operation time, and it has a low complication as well for those patients. And if the surgery is to be converted to a surgical therapy, then that can be done as well, which is an advantage. Laparoscopic surgery, no doubt, have been doing very well in the treatment of GERD, but yet, like other procedures, patients can have dysphagia. It's quoted between 10 to 15%. It can go higher in some centers, and it has some other complications that you can see. The failure rate has been reported to be around 10 to 15% in short-term therapy, and it can go into 30% if it continues for more than 10 years. So I think both are very great treatment for anti-reflux, and it's just to tailor the patient to the best kind of surgical treatment that he needs to do. Now, this summarizes the most current endoscopic procedures that have been here these days. So if you look to the efficacy, we can tell that probably TIF has the most evidence of having an efficacy controlling the gastroesophageal reflux disease. GERDIX have 3 or 4 trials so far as well, but it's new in the market relatively, so more evidence is needed. After this, Moose, ARMS, ARMA is good. Bind ligation is a little bit controversial. For the safety, I think all of them is safe. Maybe if you didn't have a very good experience using Strata, you can have some more complications, but they are generally safe. And this depends on the way that you've been looking into the device, trained, how many cases have been supervised and looked at. Technical difficulty relatively is higher in TIF because of the steps that you have to do, and you have to be careful about doing each step, maintaining a good drop between the stomach and the esophagus. As well, Strata is a very specific kind of measurement, so it's very important to look into this and to do it in the right way so that you can have the best kind of treatment. You don't need lots of devices, so the first left 4 has an additional device to be used. ARMS, as you know, and ARMA are no, and band ligation are no as well. Looking into the history, the latest have been for TIF and Strata. Strata maybe preceded TIF with 3 to 4 years, and then the other modalities of therapy have been evolved in the market after that. The cost is relatively the same. That depends between country and country, but maybe ARMS, ARMA, and band ligation are the least in the cost among all these kind of intervention. Now, if you look into the literature, looking into the evidence of endoscopic anti-reflux therapy in preventing esophageal cancer, there is a paucity of literature. There is a very good evidence that it can reduce reflux disease per se, and a good evidence that it can reduce Barrett's esophagus. But there is no studies, long-term studies, that looked into the prevention of esophageal cancer. So I'll just show, for the sake of the time, the 2 most important papers that have been published so far. The first paper that was published by Bell and his group was published in the Red Journal, looking into 154 patients who underwent TIF procedure, and they was followed for 9 years. Out of these 150, 130 were available for follow-up, and actually 20% of those patients underwent laparoscopic fundoplication after around 1.5 years or 2 years, according to their study. So the GERD HRQL and regurgitation score have been decreased significantly, or above 50% in around 70% of patients. And probably the most important that we can tell from this slide is that Barrett's esophagus have been 2.3%, which is a little bit less than the general population with no kind of endoscopic intervention. And in their study, they did not report any esophageal adenocarcinoma reported. Strata have been there in the market for a long time. There are big advocates for Strata, and there are other groups that they think that Strata is really useless. We've been adopting Strata in our center for more than 10 years now, and we have a reasonable result that I can show later. So this study was published 10 years back, actually, looking into a lot of patients who underwent Strata, looking into the possible development of high-grade dysplasia. Patients with high-grade dysplasia who can develop Barrett's esophagus and esophageal adenocarcinoma. It was a more of 130 patients who's having either GERD, again, with no Barrett's esophagus, or patients who's having GERD with Barrett's esophagus and no dysplasia. These patients have been followed, have been randomized to either Strata or surveillance, and you can see here that the risk reduction by Strata after 7 years for high-grade dysplasia was significant. It was reduced by 13%. For adenocarcinoma, it was as well 2.4%. So this is a positive result for Strata in preventing high-grade dysplasia in Barrett's esophagus and in esophageal adenocarcinoma. Now, if you look into the literature, you will find most of the papers that looked into adenocarcinoma prevention is surgical. So this paper was published in the Red Journal, looking into 34 abstracts as a meta-analysis. They came with more than 4,000 patients followed up for surgical therapy, and around 5,000 patients have been treated medically. And as you can see, there was no great difference according to the paper if you do surgery regarding cancer. So you can see the ARS group, the surgical therapy group, around 3.8 cancers per 1,000 patients per year, compared to the medical therapy, which is 5.3. So it's just only 0.29%. And there is no significant difference comparing ARS with medical therapy when they looked into the last kind of 5 years interval before publishing this study. So what they concluded is that the risk of AEC is not significantly decreased by surgical antireflux procedure, and antireflux surgery in the setting of BE should not be recommended as an antineoplastic measures, but that can be discussed during our panel session as well. The study looked into the antireflux surgery versus the PPI risk of esophageal adenocarcinoma in Barrett's esophagus, and these patients have been followed for 30 years. You can see a huge number of patients who've been treated, who've been included in this study, more than 30K of patients and 30 years follow-up. Around 2% had surgery after having medical therapy, and you can see that the hazard ratio is 1.9 actually, so there's no very good reduction rate according to that large number of patients and this follow-up data. Now, this is a cohort study in England that looked into all patients who's having Barrett's esophagus, who's having reflux disease, and GERD as well. So they came up with more than around 1 million patients who's having GERD and Barrett's esophagus. Few of them had anti-reflux surgery, and this was a positive study. So you can see that the in GERD patients, anti-reflux surgery risk reduced by almost half. And in Barrett's esophagus development as well was good in those patients who underwent surgery. So what I can tell is that the literatures are kind of controversy. We don't have a very clear evidence that surgical, neither endoscopic intervention can help preventing patients from esophageal adenocarcinoma itself. We can confidently say that those have a great risk, benefit treating reflux disease and possibly Barrett's esophagus, but the surgery per se might not have a direct impact on the treatment of patients with esophageal adenocarcinoma as well. So I would conclude for the sake of the 15 minutes. I would say that the incidence and prevalence of esophageal cancer are greatly on the rise, and I think in the 10 years we'll see more cases of Barrett's esophagus and esophageal adenocarcinoma. So we have to get ready, prepare ourselves for a preventive methods that looked into this and how can we reduce it. The endoscopic anti-reflux procedure techniques are improving big time in the last 5 years and are more used now in different centers. The current surgical anti-reflux procedure may or may not prevent the development of esophageal cancer. And I think in the upcoming years, we will have more evidence to look into this itself. And yet, as well, the endoscopic therapy has no great evidence in reducing the incidence of esophageal carcinoma, rather than, as I said, the reflux symptoms. And probably in the past, we'll have more RCTs that looked into that for the sake of prevention of esophageal adenocarcinoma. Thank you.